Assalamu alaikum. We may start this class. Okay. The topic, as has been projected, is diseases of the gallbladder. So we may start with this first case scenario. A 48-year-old man visits his physician because he has nausea and colicky, right upper abdominal pain for past 2 days. On examination, his temperature is 101 degree Fahrenheit. Blood report shows a WBC count of 11,000 with neutrophils 78%, lymphocytes 15%, and monocytes 7%. And there is tenderness in the right upper quadrant. So it's a middle to old age man, and the presentation is that of nausea and colicky right upper abdominal pain, and the history he is giving for 2 days. Temperature is of course raised, and there is neutrophilia because the WBC count is increased, and secondly the proportion of neutrophils is 78%. So there is a neutrophilia, and the tenderness on examination is in the right upper quadrant. As we all know, the right upper quadrant has edge of the liver as well as the tip of the gallbladder. So as we are discussing this scenario in the context of diseases of gallbladder, so this condition is basically, this is a typical sort of scenario for acute cholecystitis. Okay. Now, first we need to know what are the causes of cholecystitis. Cholecystitis, like appendicitis, like pancreatitis, titis basically specifies it's an inflammatory process. Acute cholecystitis means acute inflammation of the wall of the gallbladder. Now, the main cause, the overwhelming majority of cases are because of gallstones, that is 90% of cases. Now, gallstones are quite prevalent. In United States, about 10 to 20% of the population develop these gallstones during their lifetimes. And in cases of acute cholecystitis, almost 90% are because of gallstone. The remaining 10% are because of some certain other causes, which are referred to as A calculus cholecystitis. Then there are certain severe illnesses, alcohol abuse, post-operative, severe trauma, burn, multi-system organ failure, sepsis, IV hyperalimentation, and early tumors of the gallbladder. So gallstones comprise 90%. The rest is because of all these conditions. Now the pathogenesis. What's the link between the gallbladder stones and acute cholecystitis? Now, gallstones are typically present, often obstructing the neck of the gallbladder or cystic duct. Whenever there is obstruction to the outflow of the gallbladder, there is accumulation of mucus as well as certain enzymes like phospholipases and lysolecithins, prostaglandins, and they all cause irritation of the gallbladder wall as well as they cause inflammation. As I told you, there are elaboration of lysolecithins and prostaglandins. Prostaglandins, we all know, are mediators of inflammation. So bacterial infection and perforation of the organ may be later complications which may develop in this, but the main cause of gallstone association with the development of acute cholecystitis is because of the irritation of the mucosa by these enzymes and prostaglandins. Then what about the pathogenesis of acute A-calculus cholecystitis? Acute A-calculus means absence of gallstones. A-calculus specifies there is no gallstone, but still the gallbladder is acutely inflamed. So the acute A-calculus cholecystitis may be because of ischemia. In certain inflammatory conditions and edema of the gallbladder, there is edema of the wall and it causes compression of the vascular supply of the gallbladder wall, and the ischemia may perpetuate this inflammation and edema. Then dehydration is another cause of acalculous cholecystitis. Then stasis of the gallbladder, it means the hypomotility or dysmotility of the gallbladder. This happens in certain conditions, for example, spinal cord injury. It causes stasis. And whenever there is stasis of the bile within the gallbladder, it basically irritates the mucosal lining, causing cholecystitis or inflammation. Then, whenever there is stasis, dehydration, and ischemia, the microcrystals of cholesterol basically are formed. There is basically crystallization of cholesterol within the lumen of the gallbladder, compounded by bacterial contamination and lysolecithins, and they may all cause inflammation. Usually, the cholesterol basically is in the soluble form in the bile, but whenever there are certain anomalies, as we have discussed, like dehydration and stasis, there is supersaturation of bile with cholesterol. And in this scenario, the cholesterol crystallizes. We'll be discussing the cholesterol metabolism in the context of stone formation later in this session. Now, there could be bacterial contamination of the gallbladder because of infection somewhere else, for example, liver, for example, in the gastrointestinal tract. With that contamination of the bile may cause acute acalculous cholecystitis. And the conditions, as we have previously seen, these are the ones which may cause acute acalculous cholecystitis. And the patient, as we have depicted in the scenario, presents with an acute abdomen, like acute appendicitis, like acute pancreatitis. So they all come under the differential diagnosis of acute cholecystitis. And this pain is typically colicky in nature. It is localized to the right upper abdomen, and it may be associated with nausea and vomiting. And typically there is some temperature, hyperexia, as well as there is neutrophilia. Okay. With that, we can see this photomicrograph. Here you can see the mucosal lining is fairly present there. It's not ulcerated, but these dots basically represent inflammatory cells. So there is inflammatory infiltrate throughout the mucosa as well as the lamina propria. You know, you may recall that the gallbladder doesn't have developed submucosa. So after the mucosa, we have lamina propria, and here we can see the inflammatory infiltrate. Now this, the second photomicrograph basically is showing the nature of this inflammatory infiltrate. Here you can see these are multi-lobated nuclei cells. They are all inflammatory cells, and this is the typical appearance of neutrophils. So there are neutrophils, there are lymphocytes, and there are certain histocytes of macrophages. But once the neutrophils are there, then we say that the inflammatory infiltrate is a mixed one having acute cells. So this is typical of acute cholecystitis. Plus, you may also appreciate there is hyperemia or congestion of capillaries, okay, which is again a sign of acute inflammation: hyperemia, congestion, edema, and inflammatory infiltrate. So these all comprise the morphological picture of acute cholecystitis. Symptoms, as we have seen in the scenario, abdominal pain is basically the hallmark, particularly after a fatty meal. Occasionally, nausea and vomiting or fever may occur, and the patient typically gives a history of 1 or 2 days, okay, in the case of acute cholecystitis. Now, what we need to do, how do we evaluate these cases? Now, in the examination, as we have discussed previously, that there is tenderness in the upper quadrant, and this is because of the inflammation of the gallbladder wall as well as the overlying serosa and the abdominal wall. So this irritation and inflammation basically causes tenderness. Then abdominal ultrasound may give us the clear picture of gallbladder, the stone, whether the stone is there or not, what is the situation, how much is the distension, whether there is perforation. So abdominal ultrasound is gold standard for evaluation of gallbladder diseases. Then we can have certain other investigations, that may be CT scan, abdominal X-ray, oral cholecystogram, gallbladder radionucleotide scan, elevated WBC count, and increased alkaline phosphatase. Elevated WBC count, as we have seen, there was 11,000 per millimeter cube, and the majority basically were neutrophils. Serum alkaline phosphatase is raised whenever there is an element of obstruction. For example, if the stone is a cause of acute cholecystitis and that stone moves from the gallbladder and gets impacted into the cystic duct or the common bile duct, so whenever there is obstruction to the flow of bile, we have raised serum alkaline phosphatase. Now, apart from abdominal ultrasound, all these investigations have their merits and demerits. But abdominal ultrasound usually gives us the fair idea about the pathogenesis and the morphological changes that are being taken place in the gallbladder. Here you can see this is a typical ultrasound picture of a case of acute cholecystitis arising because of the gallbladder stone, which we name it as polylithesis. Renal lithiasis is a stone for kidneys, and polylithesis is the term which we employ for stones of the gallbladder. So in this ultrasound, you may see that here this one is a stone. This is a sludge, that is the crystallized cholesterol. Okay. The stone is impacted in the neck of the gallbladder, and here you can see some distension of the gallbladder. This dimension of the gallbladder is more than a normal one. Then here you can see the ultrasound is showing thickening of the wall of the gallbladder. And external to the wall of the gallbladder, we have a peri-gallbladder sleeve of edema fluid. Here you can see these arrows are showing the peri-gallbladder wall sleeve of edema and fluid, thickening of the wall because of edema, hyperemia, and congestion, distension of the gallbladder because this case is because of obstruction of the gallbladder neck by this gallstone. So here you can see these gallstones are fairly visible on ultrasound, and they may not be visible on X-rays. This is quite opposite to the renal stones. Renal stones are basically radio opaque. They have substantial content of calcium and phosphate. But here in the gallbladder stone, the main constituent being cholesterol, the cholesterol is not radiopaque, it's radiolucent. So ultrasound, that's why ultrasound is the gold standard for detecting these stones. So they are visible like this. Then treatment, cholecystectomy is basically the treatment of choice for this acute cholecystitis. Non-surgical treatment may include palliative pain medicines, antibiotics to fight infection, and a low-fat diet. Or even in the absence of all these remedies, the cholecystitis may clear up on its own. But there is a chance of perforation, peritonitis, which has its own mortality and complication. That's why cholecystectomy is being performed, like in cases of acute appendicitis. So to summarize acute cholecystitis, we have acute cholecystitis, that is acute inflammation. This is for those who have joined later this meeting, that we have been discussing the diseases of the gallbladder. Acute cholecystitis is acute inflammation of the wall of the gallbladder. Overwhelming majority, 90% of cases, are because of gallstones. And the inflammation is characterized by neutrophil infiltration into the wall of the gallbladder. The symptoms which I have shown in the scenario were that of abdominal pain, upper abdominal pain, nausea, fever, upper quadrant tenderness, and ultrasound basically shows the image and the pathology and the morphological changes which are there in the gallbladder wall. And the treatment of choice is cholecystectomy. Although in some cases, the cholecystitis may subside on its own. The complications There are certain complications which may arise in the patient suffering from acute cholecystitis. It includes empyema, that is filling of the gallbladder with purulent pussy fluid. Then it may cause peritonitis. Peritonitis may be localized with the on the overlying peritoneum of the gallbladder, or it could be generalized because of rupture of the gallbladder. Then the gallbladder wall, because of thickening and edema and distension, it may undergoes ischemic necrosis, because once the gallbladder is wall basically is distended, the blood supply of the gallbladder wall is compromised. Similarly, the gallbladder may get attached to a loop of the intestine, and because of necrosis, there could be an enteric fistula formation. So these are all the complications of acute cholecystitis. Then the second uh, topic is chronic cholecystitis. Chronic cholecystitis, as the name suggests, is somewhat more indolent process. It's a long-standing swelling and irritation of the gallbladder wall. Women are most commonly affected as compared to men. The ratio has been between 2:1. The incidence is increases after the age of 40, especially in women, and it has some association with um, menopause and postmenopausal status, as well as obesity, oral contraceptives, and they may all have certain roles in the generation of chronic cholecystitis. Now, the here again, in just like acute cholecystitis and chronic cholecystitis, the risk factors include the presence of gallstones and a history of acute cholecystitis. So there may be recurrent acute cholecystitis, which may ultimately result in conversion of inflammation into a chronic inflammation plus fibrosis of the gallbladder wall. So acute cholecystitis, repeated episodes may cause chronic cholecystitis, and like acute cholecystitis, gallstones are the main cause or the etiological agent for chronic inflammation of the gallbladder wall. There is slight difference in the pathogenesis of acute cholecystitis or acute inflammation of the wall of gallbladder and chronic cholecystitis or chronic inflammation of the wall of the gallbladder. In acute cholecystitis is basically irritation of the mucosal lining by bile acids and cholesterol crystals, which incite acute inflammation. Whereas in chronic cholecystitis, it is the infiltration of the uh, bile constituent into the wall of the gallbladder, which is referred to as um, suffusion of the wall of the gallbladder with bile constituents. So uh, the infiltration is basically the cause of chronic cholecystitis or chronic inflammation. Here in chronic cholecystitis, there is some reduction in the mucosal folds because of the chronic inflammatory process. The infiltrate which you are seeing in the form of dots, that are the inflammatory cells, they are basically mostly they are lymphocytes as well as macrophages. So the inflammatory infiltrate is a chronic inflammatory infiltrate, which is contrary to the acute cholecystitis, in which we saw neutrophils basically were there. But here we have lymphocytes and macrophages. Here you can see there is some thickening of the capillary walls uh, because of fibrosis. Fibrosis, you all know, follows chronic inflammation. Okay. So this is about the histological picture of chronic cholecystitis. Here you can more appreciate that the lamina propria and the muscularis propria is thickened. So there is hypertrophy of the muscular layer of the gallbladder wall with some reduction in the mucosal folds. Here you can see, because of the thickening of the wall, the mucous gland is trapped in the muscular wall. These are called as the Rokitansky's-Ashroff sinuses. So entrapment of mucosa within the wall of the gallbladder. Again, it's basically a sequelae of chronic inflammatory process. And this is because of the suffusion of the wall of the gallbladder with cholesterol and other constituents of the bile. Here you can see these are the Rokitansky's-Ashroff sinuses. So there is some vascular congestion, and this chronic cholecystitis may have episodic events of acute cholecystitis as well. So chronic cholecystitis may have acute exacerbations, and similarly, repeated attacks of acute cholecystitis may lead to chronic cholecystitis. So the pathology is not that much segregated as we see in the books. So there is a fair amount of overlap. Okay. Now the symptoms of chronic cholecystitis are not as acute as that of acute cholecystitis. They comprise of chronic indigestion, vague abdominal pain, belching, burping, nausea, flatulence. So these are the symptoms of chronic cholecystitis, especially after fatty meals. So investigations include again the gold standard abdominal ultrasound. Then there could be abdominal CT scan and oral cholecystogram. They may all show the picture of gallbladder, but abdominal ultrasound is usually performed as non-investigation, not non basically. It's an easy investigation. It's not. It's a cost-effective, and it is not an interventive as other investigations are. So ultrasound is basically performed. Now, the possible complications of chronic cholecystitis include worsening of the condition, that is, um, the stone formation is increased, the hypomotility, the dysmotility of the gallbladder, indigestion, um, fistula formation. They may all take place in case of chronic cholecystitis. It may also cause pancreatitis because once the stones are dislodged from the gallbladder, they may get impacted into the they may enter into the common bile duct from the cystic duct, and then they may cause obstruction at the ampulla of Vater. So once the pancreatic duct is obstructed, it may cause autodigestion of pancreas, leading to pancreatitis, which is again an acute abdominal emergency, and it has its own mortality and morbidity. And chronic cholecystitis, chronic inflammation with stone is a risk factor of carcinoma of the gallbladder. Uh, so the second scenario was that of chronic cholecystitis. Up till now, we have discussed, for those who have joined late, we have been discussing the diseases of gallbladder. Initially, we discussed the condition of acute cholecystitis, and then subsequently we discussed the condition of chronic cholecystitis. Then there is a case. This is case 3 basically, not case. No, this is case 2. Okay. Case 1 was that of acute cholecystitis. Now, case 2, a 47-year-old man has experienced intermittent upper abdominal pain for several weeks. Physical examination shows jaundice. Labs reveal basically total serum protein of 7.3 grams per deciliter, albumin 5.2, total bilirubin 7.5, direct bilirubin 6.8, AST 35, ALT 40, and alkaline phosphatase 208 units per liter. Liver biopsy shows intracanalicular cholecystitis. Cholecystitis means stasis, the sluggish flow of bile within the intracanalicular ducts. In the centrilobular region, swollen liver cells and portal tract edema. There is no necrosis or fibrosis, and there is no increase in stainable iron. So this is a middle-aged man which presented with intermittent upper abdominal pain, and the history is not that of a few days, it's of several weeks. So whatever is the process is a slowly developing, it's slowly growing, indolent sort of process. Now the labs are important in this case. The patient has jaundice. Now there is a differential diagnosis of jaundice. Here you can see the total serum protein is 7.3 grams per liter, which is normal. Albumin 5.2, again normal. Total bilirubin is raised. It's not 1.2, it's not 1, it's 7.5 milligrams per deciliter. And out of this 7.5 milligram raised total bilirubin, direct bilirubin means conjugated bilirubin is 6.8. You may recall conjugated hyperbilirubinemia occurs whenever there is extrahepatic obstruction to the flow of bile, while this direct bilirubin is not raised in certain other conditions. So there is conjugated hyperbilirubinemia. AST 35 again normal. It's normally under the range of 5 to 40. ALT is 40 units. Again, it's within the normal range. It is up to 56. And alkaline phosphatase is raised. It is also under 50. So it's quite raised, 208. And I previously told you in this session that whenever there is an element of obstruction in any of the components of the biliary tree, right from the intrahepatic duct, cystic duct, common bile duct, ampulla of Vater, whenever there is obstruction, there is rise in serum alkaline phosphatase, because this is an enzyme which is elaborated by the lining epithelium of the ducts distal to the obstruction. So whenever there is obstruction, we have raised alkaline. So alkaline phosphatase, the rise in alkaline phosphatase is showing to us that there is some obstruction somewhere in the biliary tree. Now this has been further elaborated by liver biopsy, which shows intracanaliculaar cholestasis, especially in the centrilobular region. Centrilobular region is the first one which is affected when there is extrahepatic obstruction. There is some edema of the liver cells and portal tract edema. These are again showing some extrahepatic obstruction to the flow of bile. There is no necrosis, which happens in hepatitis, and there is no fibrosis, which happens in primary biliary cirrhosis. So these are the negative findings of exclusion in this scenario. They also come under the differential diagnosis of jaundice. We all know hepatitis, cirrhosis, they are all under the differential diagnosis of jaundice. So there is no increase in stainable iron. It means there is no finding for hemochromatosis. So they may all cause jaundice. But we have hyperbilirubinemia, conjugated hyperbilirubinemia, and there is a rise in alkaline phosphatase. So that was about this scenario. Now this scenario basically is showing extrahepatic obstruction, and one of the most common cause of extrahepatic obstruction to the flow of bile is the gallbladder stone, which is referred to as polylithesis. Now this gallbladder stone, as I previously discussed, it happens to occur in 10 to 20% of the population in the developed world. It basically affects individuals in the advancing age. Women are more common affected than men. Sometimes the ratio is 2:1. Then there is the causes of stone formation in the biliary tree or the gallbladder, for instance. So it includes biliary stasis because of so many conditions, metabolic disorders, sepsis, there could be injury to the spinal cord. Then there are certain biliary infections which may cause gallbladder stone formation. This cause biliary infection is more common in the underdeveloped world, where the gallbladder may be infected with Escherichia coli, Ascaris lumbricoides, or opisthotonus infections. Now, production of bile with excessive cholesterol could be another cause of gallstone formation, especially when we talk about stone formation in the developed world. Then there are hemolytic diseases which may cause special types of gallstones, which are basically pigment stones. Then decrease in bile salt content. Bile salts are the one which basically keep the cholesterol within the bile in the soluble form. So whenever there is a reduction in the bile salt, the cholesterol crystals basically they form a stone. The cholesterol basically crystallizes. There is aggregation of crystals and stone formation. Then cirrhosis is another cause of polylithesis. Now there are certain categories of stones Most of the gallbladder stones are the cholesterol containing mixed stones. So they have the main component of cholesterol crystals, followed by a certain amount of bilirubin and calcium. And the amount of other constituents like bilirubin and calcium basically give the color to the gallstone. So sometimes the gallstones are whitish, sometimes they are yellowish, sometimes they are pigmented or blackish in color. It all depends upon the composition of the gallstone. Pure stones are uncommon. Mostly these are the mixed stones. Mixed means a combination of cholesterol, bilirubin, and calcium. Jet black bilirubin stones are formed because of calcium bilirubinate, and calcium bilirubinate excessively accumulates in the bile under chronic hemolysis whenever there is increased breakdown of red blood cells. Now, the composition can be categorized like this. The mixed stones, cholesterol containing mixed stones are the most common one, 75 to 80%. Pigment stone, 15%. And mixed stones are basically the ones which contain cholesterol. So there is no such entity as a mixed stone other than the cholesterol, because cholesterol stones contain certain amount of bilirubin and calcium. So gallstones varying from these are the different colors and shapes of gallstones. When gallstones are when they occur as a single entity, they are mostly round to oval. But when they are multiple, they are basically multifaceted stones. Okay? So they no longer remain on. So these are different quantities and different shapes and colors of gallstone. It all depends upon the constituent or composition of the gallstone. Here you can see a gallbladder. Literally, it is filled with stones, multifaceted stones. Okay, again, these are the mixed with cholesterol. Cholesterol stones कहलाते हैं ये, and they have caused chronic cholecystitis. You can appreciate there is remarkable thickening of the wall of the gallbladder. Gallbladder is not like this. The normal gallbladder is like an uninflated balloon. It's rubbery, it's thin, but here it has a thickened wall, and this because of this stone formation. Chronic irritation, chronic cholecystitis, chronic inflammation followed by fibrosis and muscular hyperplasia leading to thickening of the wall. Here you can see there is sloughing of the mucosa that become white stones, polylithesis. Again, here you can see these are basically they have fair amount of pigment and they have mulberry appearance. So these are other category of gallstones. We have variety of gallstones. Here you can see these are the pigment stones. They are mostly associated with hemolytic syndromes. Okay? They basically contain calcium bilirubinate. Okay? So it's a pigment stone. Jet black. So stone formation basically is dependent upon these four factors: supersaturation of cholesterol, supersaturation of bile with cholesterol, biliary stasis, cholesterol nucleation, and mucus hypersecretion. So these all basically function in conjunction. Some of the factors are more exaggerated, some are less, but they all contribute to stone formation. Here you can see normally the bile salts basically are which keep cholesterols in the solution form or soluble form. So they are basically, the cholesterol basically is bound on one side by bile salts, on the other side by lecithin. The one is hydrophobic, the other one is hydrophilic, and in this way they remain suspended in the solution and they do not aggregate. But whenever there is excessive cholesterol or there is a relative reduction in the bile salts, we have the supersaturation of bile with cholesterol. And here these cholesterol basically crystallizes and it form aggregates. And this whole process is compounded by gallbladder hypomotility. So here you can see that excessive even mucus secretion, they all basically contribute to exaggerated crystallization of cholesterol, and hence we have cholesterol stones. Once the cholesterol crystallizes, It crystallizes in the form of filaments and plates, and then there are these aggregations and stone formation. There are certain factors which promote store formation, for example, mucus hypersecretion, gallbladder hypomotility, and calcium salts. They act as promoters for a gallbladder that already is containing supersaturated bile with cholesterol. So already there is supersaturation of bile, plus these promoters uh, enhance the process of aggregation and stone formation. So this is about pathogenesis of the stone. Then there was a term which we employed in the ultrasound scan, which is termed as the gallbladder sludge. Gallbladder sludge is basically the crystallized form of bile without stone formation. So it's small aggregates or just like sand in a suspended form, which basically forms the sludge. Then we have a limited number of patients in which acute cholecystitis is the result of acalculous cholecystitis. As we have discussed in the scenario of acute cholecystitis, there are certain conditions in which we have inflammation of the gallbladder wall without stone. So these 5 to 15% of patients are basically are the ones which are in the ICUs, which are in the CCUs, which have major trauma, major surgery, and they have protected prolonged illnesses. So these individuals are prone to develop acalculous cholecystitis. Then pigment stones, as I told you, pigment stones are formed because of crystallization of calcium bilirubinate. It is because of increased destruction of RBCs, hemolysis, abnormal metabolism of hemoglobin, cirrhosis, and infections, including parasitic infection. This last cause is the cause which is more prevalent in the underdeveloped part of the world. So, underdeveloped countries, we have certain infections. The common ones are the Escherichia coli, E. coli, and Ascaris lumbricoides. While in the developed world, we have certain other conditions. So, pigment stones basically are formed because of these conditions. Although infections play their role in mixed stone formation as well. Then symptoms of stone gallbladder stone may remain asymptomatic for years unless it produces certain complications, and then it can present with recurrent sharp cramping or dull pain. The pain typically radiates to the back or below the right shoulder blade, typical dermatome arrangement, made worse by fatty or greasy foods, and occurs within minutes of a meal, especially a fatty meal. Then it may be accompanied by jaundice or fever. So these are all the symptoms and signs which may appear in a patient harboring these gallstones, but in many cases they remain symptomatic. There are silent stones. Sometimes they are the findings in which is being basically done for any other disease process, but then in the ultrasonologists say that we seen so many stones in the gallbladder, and the patient has time to do elective surgery of the gallbladder, because if it does not imply this surgery, then it may present with an acute abdomen or an emergency. So it's better to have an elective surgery of gallbladder, okay, if the stones are there, because there is a definite risk of acute cholecystitis, chronic cholecystitis, even carcinoma of the gallbladder, plus the complications. So it's better, it's wise to have elective surgery. Then additional symptoms of gallstones may include undigested fat in the stool, that is the clay colored stools, nausea, vomiting, heartburn. These are all vague symptoms. Excess gas, okay, or abdominal indigestion and abdominal fullness. So they may all be seen in patients suffering from gallbladder stones. Treatment comprises of these two medical treatments, chenodeoxycholic acids and urodeoxycholic acid. They basically dissolute uh, the formed gallstones, as well as they prevent new stone formation. They are basically employed in conjunction with the shock wave lithotripsy lithotripsy so as to break these stones. But this medical and lithotripsy is second line treatment in these patients. The treatment of choice remains surgery, general surgery, and removal of the gallbladder with stones. Possible complications which may arise because of stone: acute cholecystitis, chronic cholecystitis, cholangitis, choledocholythesis. It means obstruction of the cystic duct. The term is choledocholythesis, that is obstruction of the cystic duct. Then pancreatitis because of obstruction of the pancreatic duct. Sorry. So they may all basically result in. Let me go to the slide. So these were the possible complications of polylithesis or gallbladder stones. Here you can see this is the liver, and the gallbladder fossa. We have gallbladder, multiple stones are there, and these stones have blocked this cystic duct. They have entered basically into the bile duct. Here you can see. So they are blocking the basically biliary tree. Now this is the last case. A 55-year-old man has developed abdominal pain and severe jaundice that developed over a period of several weeks. There is severe weight loss and right upper quadrant pain, but no abdominal distension. An abdominal CT scan shows markedly thickened gallbladder wall. Cholecystectomy is performed and shows a fungating 4 into 7 centimeter firm lobulated and tan mass in the wall of the gallbladder. So this is a patient which has presented with severe jaundice. So these patients usually present with very high levels of bilirubin, and the main chunk of that bilirubin is a conjugated one, and this is because of the obstruction of the biliary tree. So this obstruction on the ultrasound, on the CT scan, even ultrasound can pick this mass in the wall of the gallbladder, and the mass is a fungating one, 4 into 7 centimeters, lobulated tan mass in the wall of the. So this mass, 4 into 7 centimeters, is nothing but a tumor in the wall of the gallbladder. And carcinoma, adenocarcinomas arise there, and these adenocarcinomas basically by the time they are detected, they have already have caused local invasion as well as distant metastasis. So they have very bad prognosis. So fortunately they occur less, but once they are diagnosed, then they have very bad mortality. The 5-year survival rate is less than 20%. So carcinoma of gallbladder, 6,000 new cases of adenocarcinoma per year in the USA they are detected. They are slightly more common in women, and the mean age at the diagnosis is 70 years. So the age of diagnosis, average age of diagnosis of gallbladder cancer is 20 years more than gallstones and cholecystitis. Risk factors include postmenopausal status, cigarette smoking, gallstones, 85% of cases, porcelain gallbladder. Porcelain gallbladder, there is a fusion of the wall of the gallbladder with calcium, salts, and cholesterols, and the gallbladder becomes like a rigid pot. That is called as a porcelain gallbladder. It is again because of supersaturation of cholesterol of the bile, supersaturation of bile with cholesterol. And then there could be choledochal cyst or cystic duct cysts may also cause adenocarcinoma of the gallbladder. Plus, there are conditions which are associated with chronic biliary reflux of pancreatic secretion, such as anomalous junction of the pancreatobiliary ducts is the congenital abnormality. Then low insertion of the cyst, again a congenital abnormality. So they may cause excessive secretions of pancreas, infusion into the gallbladder and the biliary tree and the liver, and they are the cause of carcinoma of the gallbladder, which has very worse prognosis. Here is the porcelain gallbladder. This gallbladder has been converted into a rigid pot-like structure. That's why it's called as the porcelain gallbladder. It is because of the infusion of the gallbladder wall with supersaturated bile containing cholesterol and calcium salts. So it is being calcified. You may use the term dystrophic calcification in this case. Okay, because of the inflammation and damage and ischemia of the gallbladder wall, there is accumulation of calcium salts, dystrophic calcification leading to porcelain gallbladder. Porcelain gallbladder is a definite risk factor for adenocarcinoma of the gallbladder. Here you can see this is a fungating mass which is protruding into the lumen of the gallbladder, and it is also associated with these multiple stones. This is a typical picture of carcinoma of the wall of the gallbladder. Here you can see these are the mucosal lining, these are the gland, but they are all lined by anaplastic cells. This is not normal. These anaplastic cells have caused this. They are basically the cancers. They are the adenocarcinoma. They have infiltrated into the wall. I may show you the normal lining. The normal lining is like this of the mucosa, like this. These are the normal cells. Inflammation in me, but they are the normal ones. But here you can see, so these are totally abnormal cells which are lining the mucosal folds, and these are all anaplastic cancer cells. And they have infiltrated into the wall of the gallbladder, and by the time this tumor is detected, it has already have escaped beyond the gallbladder into the liver, into the lungs, into the bones. So it's a very devastating condition, adenocarcinoma of gallbladder. So it may be fungating mass, it may be an infiltrating sort of adenocarcinoma, it can be papillary in structure, and mostly these are poorly differentiated, moderate to poorly differentiated cancer. Sometimes squamous cell carcinoma may also arise in the gallbladder. Clinical features include relentless pain in the right upper quadrant associated with weight loss, jaundice, and palpable mass. The tumor is seldom limited, to, as I've told you, to the gallbladder. Approximately 90%, 95% of patients die within first year of diagnosis because of the spread of the tumor. 5-year survival rate is less than 10%, often as low as 1%. It's a devastating condition, but fortunately, its incidence is less as compared to the polylithesis, acute and chronic cholecystitis. With that, we came to end of this session. Thank you very much. You may mail me your questions or so that I can answer, and you may copy these slides. Thank you very much.
Assalamu alaikum, sir. Hello.